So thank you, madam, and students also joining this event. Though our today's casualty day, I think most of others, the unit registrars will also join. Madam, can you hear me? Or students, can you hear us?
Yeah.
Yes, you are loud and clear.
Yes. Okay. I think you are okay. Nilan has thought that we are starting at 5 o'clock.
Typical surgeons.
No, we had time change, so that's a problem. Anyway, now I think that's okay. We'll start.
Right. So we thought I'll just today we're going to talk on intestinal obstruction. I'll take only 2 minutes to give a brief introduction and tell you what we are going to talk today, right? And from there on, we will continue.
Yes.
So last time we talked about hernia, and there we mentioned the one of the severe complications or serious complication of any hernia is obstruction or bowel obstruction. And we talked a little bit about bowel obstruction, but today we are going to talk on intestinal or bowel obstruction in more detail. And when we talk on bowel obstruction, the term bowel obstruction, it's not a single disease like appendicitis, cholecystitis, pancreatitis. It is a clinical condition which have a different anatomy. So intestinal tract is a one long tube which subserve different functions at different sites. So obstruction in this long tube, usually at one point, or you may get sort of more than one point also. It's called bowel obstruction. And so there may be obstruction in small bowel, stomach, outlet of the stomach, large bowel. So anywhere you can get obstruction. So there is no definite anatomy like in appendicitis or cholecystitis. And even there is no definite pathology also. Bowel obstruction can occur due to tumors, can occur due to problems outside bowel also, like adhesions, right? Problems within bowel also, like foreign body intussusception, and sometimes due to neuromuscular issues like paralytic ileus, bowel doesn't work. So there is no definite pathology also.
Sir, can I interrupt for a moment? Now, you said there is no definite anatomy, but can we say, as a general term, when you say obstruction, you are talking about maybe due to some process, some disease pathology, some process, there is some interruption to the passage of its contents. Can you say, common term, can you say that is the basic pathology in obstruction?
I didn't follow you, Rohan.
Okay, you can't give a clear anatomical description, but still, functionally, when you say obstruction, there is a problem in the continuity of the passage of contents inside intestine. So that is a basic problem.
Yeah. So though there is no definite anatomy, though there is no definite pathology, right? There is one common issue. There is no continuous flow within this long tube in bowel obstruction. So there's a stagnation, right? And intestinal tract is continuously fed from what we eat and drink, as well as sort of from the secretions from inside, right? It may be coming from stomach, it may be coming from pancreatic secretions, may be coming from bile, intestinal glands, anywhere. So When there is obstruction, there is accumulation and stagnation.
So, Mudhu,
So,
can I ask a question at this point?
yes.
Excuse my ignorance, but when you say bowel obstruction, do you count, say, gastric outlet obstruction also?
Yes.
Doesn't that go in a different group, like like pyloric stenosis and all go as a different group, or does that come under the umbrella term of bowel obstruction?
Madam, we call intestinal obstruction, we call gastric outlet also as a bowel obstruction. Only esophageal obstruction, we don't usually talk under obstruction, bowel obstruction. But yes, gastric outlet obstruction also.
Yeah, esophagus is also part of bowel, but still,
yes, of course.
As surgeons, when you talk about bowel obstruction, you don't really you actually can exclude the esophagus. I think probably because it's outside the peritoneal cavity. Maybe that is the cause. But anyway, I also like if you're answering the question that Prof. Janaki asked. So stomach, duodenum, small bowel, large bowel, they manifest differently. The clinical manifestations, how they present, the type of complications that you get, they are different. But still, in principle, as we discussed, the basic problem is there is a problem in continuity of the flow. As a result, there is stagnation.
Good, thanks.
Yeah, and the manifestations also differ. And outcome also in bowel obstruction, not like sort of pancreatitis, there is a sort of standard sequelae, expected sequelae, but bowel obstruction, it has a sort of different outcome. Some patients recover without any problem, others progress, right? Others may go on for many years, many months, right? With symptoms. So this is a clinical condition which has no definite anatomy, no definite pathology, no definite sequelae as well. But we will talk on sort of common clinical manifestations of bowel obstruction when we go on. And we are going to talk on how do we diagnose intestinal obstruction. This is very important. Diagnosis of intestinal obstruction. Is it clinically, radiologically, or any input from biochemistry as well? Then we will talk on basic information we need in the management of intestinal obstruction. Very basic information, or we should try and gather information regarding the site of the obstruction when we encounter a patient with intestinal obstruction. Then, if possible, the cause of the obstruction. And it is important to know whether it is a complete obstruction or a partial obstruction also. And we are worried about complications of obstruction also. Mainly, the complications occur in the bowel, like necrosis, perforation, impending perforation. Then another set of complication in the fluid or dehydration or related to hydration and electrolytes. Then another set of complication in chronic obstruction in relation to nutrition. And there are heaps of other complications as well, like sort of risk of aspiration, renal insufficiency, septic complication due to gut translocation, likewise. So basic information, we want to know the site of the obstruction, cause of the obstruction, whether it is complete or incomplete, or whether there are complications, or whether there are impending, or are we going to face complication in near future.
So now,
then we may talk about that.
Yeah, when I was listening, what I felt was there are large, lot of areas that you need to discuss. And you can't
sometimes we may not be, sometimes we may not be able to discuss all these areas. So that is why I mentioned these are the sort of things under bowel obstruction, which probably we may have to think of.
Yes.
And lastly, we may talk about management and special concern about the place of surgery in the management of bowel obstruction. And if time permits, we may discuss about few scenarios of bowel obstruction. So,
okay, shall we discuss?
With that, Rohan,
we said the diagnosis and presentation is very important, but I think out of all, one of the key, when we talk about bowel obstruction, we talk about three cardinal things: colic abdominal pain, distension, and constipation. Depending on the degree of obstruction, may be absolute or relative. So basically, these are the three cardinal things. But I think out of these three, pain, I think, is the key. And why now? Why are we so worried about the pain? And if I'm taking a history from a patient with obstruction, I would specifically go into the details of the character of the pain, how the pain started, how it progressed, what is the type of pain that the patient had when it started, and has the character changed. And I think that is very, very important as far as coming to a diagnosis of obstruction, and also finding out whether this patient is having a serious complication because of obstruction. Now bowel, madam, can you will you be able to tell us about the pain? What kind of pain do people get from bowel related pathology? So how do you get pain? Or is it, are we the best to talk about that, or madam, will you be able to tell us? Jani madam is there?
Yeah, madam is there. Can't hear you, madam. Madam, we can't hear you.
Sorry, I have unmuted. I have unmuted now. You all probably are the best, but one of the types of the pain would be the colicky pain, would be because of peristalsis becoming aggravated to overcome the obstruction. Am I right?
Yes.
The other one would be the pain partly due to the inflammation, because as you know, the cardinal symptoms of inflammation, one of the things is pain. So that type of pain is caused by different things like mediators of inflammation, like prostaglandins, giving rise to pain. That's the type of pain you get in acute appendicitis, the inflammatory pain. Apart from that, I can't think of any other mechanisms for pain.
Madam, now, now you said, now we are talking about colic. Now we said
ischemic pain.
Yes, ischemia also can give rise to pain. That's where the nerve endings would be ischemic and giving rise to pain. That's also a possibility if there's ischemia.
So there are three main types of pain in bowel, which we can think of. One is the obstruction leading to colicky pain, and inflammatory type of pain, and ischemic pain. So as Rohan said, it is very important to recognize the different types of pain. So history plays a major role here. One thing is to diagnose intestinal obstruction. Other thing is to recognize the status of the intestinal obstruction. So if I say it is basically a clinical diagnosis, which needs which needs sort of proved by radiology or X-ray, other modalities, but it is basically a clinical diagnosis.
Can I ask one more question?
Can you highlight sort of different?
So can I ask just one more question about the pain from Janaki madam?
Yeah.
Now we have, if you take the large bowel and the small bowel, the type of and the severity of the pain is different with obstruction. Madam, is there a difference in the muscle wall thickness or the musculature of the large bowel and the small bowel? Because if you get, if your contractions are very severe, your contractions are very strong, the pain that you get because of colic is very severe. So is there a difference in the small bowel and the large bowel when you look at the muscle wall thickness?
Yes, definitely. There is. Now, for example, starting from the stomach has 3 layers of muscle, circular, oblique, and longitudinal. When you come to the intestine, both the large and the small intestine have similar type of musculature, but the thickness is different in the two. Right? So that may also account for the different amounts of pain you see in the two organs or systems.
Yeah. So generally, if you are seeing a patient with small bowel obstruction, their colics are very strong, and probably that is the reason why they get these strong colics, because their small bowel, the musculature is quite thick and the contractions are strong compared to the large bowel. And in large bowel obstruction, generally you don't see a lot of pain. I think probably because your contractions that you get in the large bowel is much less compared to the small bowel. So probably that is one way of finding out clinically, by looking at the severity of pain, the site of the obstruction. Isn't that so, Mundu sir?
Yeah. One other thing is, now small bowel is supplied by T10. So this pain is localized or felt mostly in circumumbilical or around the umbilical. And large bowel, of course, it is a more diffuse type of a pain you feel.
But just yeah, one more question. But now just discussing about the topic, but we don't see, if let's say someone is having gastric outlet obstruction, we don't see a lot of pain, and they don't come with pain.
Yeah.
Or is there a reason for that? I'm not sure.
Yeah. What I feel is, now gastric outlet obstruction, they also have more than pain, they have more discomfort. Stomach is more capacitous, right, compared to the rest of the bowel. Now you see that now compared to the gallbladder pain, when there is an outflow obstruction in the gallbladder also, they don't get, most of them don't have sort of typical colicky pain in gallbladder also. They have crampy pain, sometimes might bit of a discomfort. That is partly because sort of the proportion to the wall to the lumen is lumen is relatively smaller, bigger than the wall. And when there is the stomach, of course, you can empty it by vomiting. So when they have obstruction, stomach has sort of more vigorous contraction when they try to expel it out, so it refluxes back and they vomit and empties it. But small bowel, we may not be able to empty unless we facilitate it. So by emptying small bowel obstruction, by placing a nasogastric tube, we really reduce the amount of pain.
So that is the principal basis behind passing a nasal tube. Because when you probably one reason is you decompress the stomach, small bowel, duodenum, in turns the small intestine, and it will decompress, and that will reduce the pain. So is it only the reason that we pass NG tube? Are there any other reasons? How else will a NG tube help a patient in an obstruction? I think before that, I think we better discuss a bit about pathology or how it damages a small bowel, answer.
Yes. And diagnosis, should we talk about now clinical diagnosis?
Yeah.
Now, small bowel colics, of course, we can recognize the other things. When there is an obstruction, suppose if it's a complete obstruction, the things accumulate proximal to that. Rohan mentioned 4 clinical features. One thing is pain, other thing is vomiting, and the other thing was constipation and distension. So, Pramod, shall we discuss sort of how these 4 symptoms vary in different parts of the intestinal tract?
Yeah, I think.
For example, if you take sort of more proximal obstruction, which clinical features are more prominent, and the other end, colonic obstruction, which clinical features are more prominent? And the basis behind sort of, we talk about the pain, the other things, distension, vomiting, and constipation. Why do they get that?
I think if you have a more proximal obstruction, vomiting will be more prominent other than constipation, because there is already the bowel content that has traveled past the site of obstruction. So absolute constipation will not be there. You can't depend on that. But vomiting will be more pronounced. And also the dilatation or the distension of the abdomen will be less if you have a more proximal obstruction, because the amount of bowel that is distended will be less. And also, as we know, whether the content is bilious or not will help you to sort of infer whether the obstruction is proximal or distal to the second part of the duodenum. If it does not contain...
Then you get extremely the other side, colonic obstruction, you get feculent vomiting. Yeah. When you get more proximal obstruction, you get bilious vomiting. And probably in the ileum, you get brown color or earlier you get greenish and you get more yellowish and brown vomiting.
Yeah. And colonic obstruction, the constipation,
yeah, I think Pramod's line went off.
Or this frozen.
Yeah, anyway, yeah, so what he was telling is if the obstruction is in the colon, the constipation is a predominant symptom. But the problem is, having said all that, and the obstruction does not happen all of a sudden at once. It's a progressive thing. So you tend to develop symptoms over a period of time. At one point it obstructs, but then patient might present you at different points of their progression of symptoms. One patient might present you right at the end of at 100% obstruction. Someone might present at 50% of obstruction. So it's a very series of symptoms that you might get depending on the time of presentation of obstruction. So that's what Dr. Sumudhu Kumar said, that it's you can't say you study, okay, these are the cardinal symptoms of obstruction, these 4 symptoms, but you don't see the typical picture in each and every patient because their time of presentation may vary to you. So it's very important to understand, even if you study these 4 things, that is not the way the patients present to you most of the times.
And regarding constipation, the bowel motions, the most important is presence of bowel motion doesn't exclude intestinal obstruction. Yes, Pramod, you are back in the line.
So
now we talk about vomiting, we talk about pain, constipation, then the distension.
Yeah, so as I said, the distension will be much more as you have a distal obstruction, because the amount of bowel that distends is greater. So like if you have a distal ileal obstruction or a proximal colonic obstruction, your whole small bowel will be distended with content and gas, and your distension will be more prominent. As opposing to if you have a gastric outlet obstruction, your distension will be mostly minimal, or you will be getting vomiting before the stomach distends and presents with a abdominal distension. You will start vomiting and emptying the stomach.
Pramod, you said distension is a cardinal feature. Now, with what does this bowel distend? What is from what you get the distension? Is it?
Yeah. So there are several factors that affect the distension. So when there is a block, number one, very obviously the secretions of the intestine, the bowel, the pancreatic contents, and those things usually get absorbed as they pass along the bowel. Now the bowel is obstructed and they don't pass into the absorptive surface. And also the distension itself, when distension starts to develop, the venous congestion will start excreting, sort of having edema fluid flown into the lumen of the bowel, which increases the content in the bowel. And also the absorption is reduced because of the venous congestion and the blockage. So and also later on we can talk about also the bacterial fermentation might add up to gas accumulation inside the bowel. So all of these add into the distension. It is a combination of these factors.
So distension is not only fluid, but also air as well, isn't it?
Yeah.
Pramod?
Yes. Yes, the gas as well, both the solid gas as well as the
when we take X-ray, we see lot of. That is why when we take X-ray, we see air fluid levels.
Yes. Yeah, correct.
In normal X-ray, we don't see air fluid levels, especially in small bowel. But in intestinal obstruction, we do see air fluid level because this is distended not only with fluids but also with gas.
Yeah, now we studied Starlings forces during physiology. Now, does it help us to explain how this edema fluid forms in obstruction excessively? Does it help us to explain that?
Yes, I think the pressure in the venous end increases. So usually the Starling forces describe that there is extravasation at the arterial end, and then there is a reabsorption at the venous end, and there is oncotic pressure due to the serum albumin that affects this mainly, and also the low venous pressure. So the venous pressure here becomes high because there is a mechanical obstruction, and then because of that, the reabsorption of the fluid is less. So there is an imbalance between the extravasation and the reabsorption. So disruption of the Starling forces cause accumulation of the fluid, both in the interstitial space as well.
So, madam, now in intestinal obstruction, there is now extravasation, as Pramod said, there is extravasation of fluid. So there is a bowel edema also. And there is fluid pouring into the gut lumen also.
Lumen, yes.
Right. So when the gut wall is edematous, it doesn't sort of function as usual. The absorption is also hampered, isn't it?
Absolutely, yes. And that leads to further ischemia as well, because your perfusion reduces after that. Yes?
Because of bowel wall edema.
Exactly.
Yeah.
So with obstruction comes ischemia, and with that necrosis, and we'll talk about that later as the outcome of obstruction, no, once we go along. Without jumping.
No, now we are talking about recognizing the site of the obstruction, as Pramod said. These 4 symptoms help us to guess where the obstruction is, right? Whether it is proximal bowel, whether it is distal bowel, the mid bowel, gastric outlet. So these 4, the chronology of the onset of these symptoms, as well as the severity of the or prominent symptoms, help us to recognize where the obstruction is. Right. What is this?
That's a pathophysiology of the Starlings forces.
Yeah. Madam, you are going to
no, this is not mine.
This was a slide which I had.
This is Pramod's.
Yeah, in the lectures. So just to show the what I was explaining, the secretions and reduced absorption, causing the sequestration of fluid in the bowel lumen. And so there is a fluid shift. And also, if we want to talk about the bacterial translocation as well at the same time, due to the ischemia of the mucosa, the mucosal barrier gets disrupted because, as Madam mentioned, there is ischemia, and the ischemia causes the tight junctions because, as you know, there is a large number, the trillions of bacteria that lives inside the gut lumen, and they are being separated by a single cell layer from the interstitium. So the mucosal barrier, the tight junctions get disrupted, and the bacteria starts to translocate into the systemic circulation.
And Pramod, last time we discussed that it is the endothelium, epithelium that gets disrupted because that has the highest turnover, has metabolic demand. So when there's ischemia, it is the epithelium that gets disrupted first because the demand is high. And that is when it gets disrupted, as you said, the translocation, the bacteria starts to migrate from the lumen across the lumen into the wall as well as outside. So that's how it happens.
So now we were clinically we can guess the site, but we need most of the time we need the accurate site of the obstruction, isn't it, in the management of intestinal obstruction. So So probably we need more refined way of finding where the obstruction is. Rohan, how do we what can we do to recognize the exact site of obstruction?
I
And
think,
even to confirm whether there's an obstruction also.
Yeah, I think clinical examination again is very important at the initial assessment and your follow-up. And when we examine these patients, their abdomen is distended and then they come with pain. But then when we examine, we would like to find out where does he have a place where there is excessive pain. So we would closely examine the abdomen and try to find out, is there a specific point which contains excessive pain. Now that is very important to find out. Now, we were discussing, okay, these patients come with colic pain. Colic pain is because of the obstruction. Because of the colic, they get pain. And then we came into a discussion. When there is obstruction, there is wall edema, and wall becomes ischemic. And as a result, sometimes you get mucosal damage, and bacteria starts migrating out. And if it further progresses, ischemia leads to areas of infarction and localized inflammation. And that's a different type of pain that they start complaining. And on top of they will start with the colic pain, but later on this colic pain, probably they will start complaining of, okay, in this place I have more pain compared to rest of the abdomen. And when you start examining, you find a place where there is excessive tenderness, and that is a place where there is impending ischemia or already established ischemia. As a result of ischemia, they get localized inflammation and localized peritonitis, and that is a place, and that is a sign that patient is going into a complication. I think that is the first place to start.
So the presence of now just mere obstruction cause pain, but the abdomen is soft and untended. So if he has a tenderness in excessive or prominent tenderness in one area, that means there is a localized inflammation due to obstruction. So probably it is a place which is going to cause problems. Is that correct, madam?
Yeah, madam.
Yeah. But how often do you see this localized pain in the ward situation? Are you able to localize the pain that well? I'm talking in terms of clinically.
Commonly, we get localized pain in hernias, obstruction due to hernias. If they get sort of tenderness at the site of the hernia, we are very worried that whether there is impending ischemia or not. That may be groin or in the femoral hernias. So it is important to see sort of whether there are hernias as well as sort of, as Rohan said, localized tenderness and somewhere in the abdomen.
And one more instance, when we are, I think we would come to this discussion later on, but when we are managing a patient obstruction, we would look at a virgin abdomen in a different way compared to abdomen which was operated in a different way. If someone is having operated the abdomen, we are generally thinking, okay, this is a subacute obstruction, or this is an obstruction because of adhesions. Now, in these patients, we are not rushing for operation because there's a chance that they might resolve with conservative management. And also, if you go in and operate, they get more adhesions, and the next time they can present with worse episode of obstruction. So in these patients, we manage conservatively and we observe them. And these patients, very important to find out whether there's a site of excessive tenderness. So that indicates that in one part of in the patient's abdomen, there is impending or developing this damage of bowel. So that is the place, that is the time you start intervening. So that's it. I think that is the second category of patients where localized tenderness is important.
Yeah, absolutely. And as he said, now the examination of the abdomen is important, and at the same time, the other parameters, examination of the other parameters like pulse rate is also important in this patient. They can have tachycardia commonly due to dehydration. But once resuscitated, also if they continue to have tachycardia, which cannot be explained, that is also a very worrying sign. and the change in the pattern of the pain and abdominal signs and other clinical parameters, tachycardia, tachypnea, which are telltale signs of impending bowel ischemia. But clinical features, clinical signs will help us to or guess it, but it is not very accurate, isn't it? I feel sort of they are in a way they are very helpful to prompt us to do investigations very quickly. What investigations will help us to recognize the site of the obstruction? Or what investigation, of course, will help us to confirm the presence of obstruction?
Sir, now can I, okay, first, I think first important thing that you have to establish is, okay, whether this patient is having obstruction or not. That is the first question that you need to answer. Yeah. I think the traditional way is to start with the X-ray abdomen. And generally, if you ask someone, you
what X-ray abdomen
tell us.
What
most of the students will tell us. Okay, most of the students will tell us, okay, we will do a supine X-ray or supine and erect abdomen. That is the traditional answer that we get if you ask that question. But in the erect abdomen, okay, you will see multiple fluid levels, and that will tell us, okay, this patient is having obstruction. But then by the time we do a X-ray, we have already made a clinical diagnosis. But I think most important X-ray is a supine X-ray. Erect X-ray will not give you additional information. If you do a supine, now this picture shows a good supine X-ray abdomen. And in the supine X-ray abdomen, you see distended small intestine, and that is diagnostic of intestinal obstruction. And then by looking at the different characteristics of the bowel, intestines, you can say, okay, this is a small bowel, this is a large bowel, by looking at the supine X-ray. So the supine X-ray abdomen is the most important investigation that we started.
So that means sort of supine X-ray abdomen will tell us two things. Erect abdomen will tell us only whether there is obstruction or not. But if you do a supine X-ray abdomen, you get an idea about the site of the obstruction as well. Whether it is proximal small bowel, whether it is distal small bowel, or whether it is a large bowel obstruction. So what characteristics in X-ray will help us to recognize the site of the obstruction?
Okay, I think first question that you need to answer is whether it is large bowel obstruction or small bowel obstruction. Now, this is a good X-ray. Now, if you look at this X-ray, Pramod. Yeah, Pramod, probably you may describe this.
Yeah, so as you can see, the before that, if the patient is having sort of a irreducible hernia or evidence of strangulated hernia and so on, I think we don't need any investigation to go ahead with correcting it. This is only when there are no external indicators of a definitive cause for the obstruction. So this X-ray shows, as you can see, with the arrangement of the bowel loops and especially what we call the valvular conjunctives. So they are completely dividing these gas-filled, distended bowels. You can see these small bowel loops are distended, multiple loops arranged in the central abdomen. They are distended, and the valvular conjunctives are separating them completely into segments. The shadows of the valvular conjunctives are complete across the bowel wall, the full diameter of the bowel wall. And also you can see there is no gas on the left side where the sigmoid colon is supposed to be, and or the rectum. The rectal gas shadow is missing, and there is no gas in the sigmoid colon. So this X-ray is clearly indicative of a small bowel obstruction, and based on the amount of small bowel that is distended, I would say this is rather distal small bowel obstruction.
Right.
And also, Pramod, to add on to that, we and also we can have idea about how bad the obstruction is by looking at the diameter of the intestines. If you look at the if you take the cecum, if it is muscle distended, if it is more than, generally traditionally talking, if it is more than 12 centimeters, you consider that there is impending perforation. Is there a size for the small bowel like that, or cutoff size, or it's just eyeballing observation that you take?
That's 6 to 7 centimeter cutoff margin, if I'm not mistaken. For large bowel, it's 10, and for cecum, it's 12. That's okay. But these are very arbitrary. Because
arbitrary, but
yeah, if the small bowel obstruction was sort of developing throughout, for example, in a patient with a inflammatory bowel disease stricture, which has taken a long time to develop slow obstruction, their small bowel may be much distended than 6 to 7 centimeters, as opposed to someone who is having a acute obstruction, and the perforation, the risk of perforation is less because it's being distending over a period of time. The bowel wall has sort of acclimatized to the high pressure. So it's all arbitrary, I think. But the impending obstruction, I would basically depend more on the clinical findings, or the clinical aspect, the clinical condition of the patient. And so we don't decide to intervene based on basically just the size of the bowel shadow. It's a combination of clinical findings, I think.
Pramod, when do we consider CT scan in the intestinal obstruction? Do we do regularly, or sort of?
Now, yeah. So in this day and age, we have a very low threshold for CT scan of the abdomen. If you do not have, as I said, obvious cause like a inguinal hernia or any other anterior abdominal wall hernia which is causing obstruction, or if the patient, or if the patient is not you're not suspecting adhesive obstruction, where the patient gets intestinal obstruction frequently, like a couple of times a year. In a virgin abdomen especially, I will have a very low threshold to go for a CT scan. Like it would be sort of like a first line investigation in this day and age, with the facilities are available with IV and oral contrast, both. So I would say in a virgin abdomen, if the service is available, I would always prefer, if there are no external indicators of a probable cause, I would always go for a CT scan of the abdomen, because then we will know what we are dealing with. And,
so what you are trying to tell is the bare minimum initial investigation in intestinal suspected patient with intestinal obstruction is supine X-ray abdomen, which help us to confirm the diagnosis and get an idea about the site of the obstruction. But to find out exactly the exact site and the cause of the obstruction, which is very unlikely be revealed in the X-ray abdomen, we may have to do a contrast CT abdomen. Yes. So contrast CT will help us to find out exactly the site and the cause of the obstruction in reasonable number of patients. And one other thing is whether it is complete obstruction or not. Right. Now, talking about complications of obstruction, madam, come back to you after refreshments, probably.
I'm here.
Yes. So what are the possible, or what are the anticipated complications of complications a patient having intestinal obstruction?
So the obvious complication which we have already alluded to is ischemia. And as you know, yes, ischemia leads to necrosis. Ischemic necrosis, if you remember your first few lectures in pathology, is called infarction. In the bowel, there is another type of necrosis that occurs, known to the surgeons as gangrene, though it's not really a pathological term. It means that there's infarction with superadded bacterial infection. So as you you would have heard earlier Dr. Pramod and Professor Rohan discussing, there's transmigration of a lot of organisms, and that's why very often the necrotic bowel undergoes infection and gangrene. So the next step in a gangrenous bowel is it's very friable and it can perforate, and obviously then it leads to peritonitis. So that's the kind of sequelae of ischemia occurring in obstruction and the general outcome if you don't intervene in a timely manner. There are few things I'd like to stress at this point. Ischemia will lead to necrosis at some point, but ischemia doesn't always mean necrosis, because if you remember, there are 5 important factors that determine whether ischemia leads to necrosis. That is the type of tissue. In this case, it's a bowel we are talking about. And in the bowel also, you have certain zones which are more likely to get ischemic. Am I right, Samudhu, like the watershed zones, like the splenic flexure and all? Because they are the regions between 2 blood supplies. So the type of tissue, the duration of the ischemia or the impaired perfusion, the amount of collaterals, these are some of the factors which will determine whether ischemia will lead to necrosis and how often it will lead to necrosis, right? So remember, necrosis, gangrene, then perforation. Those are the general steps that will occur. Having said that, Sumudhu, can I ask you a question? Now, from all this, we were talking that it's important to establish that there is obstruction. It's important to try and identify the level or site of obstruction, but you all didn't throw a great amount of stress on the etiology. Is that because when there's obstruction, irrespective of the etiology, you have to go in, and the etiology doesn't really matter too much?
Not really, madam. Now, if there is when a patient comes with intestinal obstruction, initially we want to establish the diagnosis of or confirm that there is an intestinal obstruction. Then, whatever the etiology, we have to decide. Our next priority is to resuscitate this patient. That means sort of if it is sort of if the patient comes after a few days, or sort of when there's a distal obstruction, they are dehydrated, they may be having electrolyte issues. So we have to address those 2 issues. The next priority is to see whether there is impending complication or established complication. As you said, ischemia, gangrene, perforation, peritonitis, lastly death. Right. So
that's too late.
So our priority of management is establishing the diagnosis, then resuscitation, fluid electrolytes, then not then at the same time to see whether there is impending complication. If there is an impending complication, of course, whatever the reason, whatever the cause, right, we may have to go in. But another group of patients who don't have those complications, we have enough time to sort of do resuscitation, we correct electrolytes, and then we are looking for a cause for the obstruction, and at the same time we see whether it will recover spontaneously or not. Some causes of obstruction recover spontaneously, and some others will never recover spontaneously. If we recognize a obstruction which will never recover spontaneously, we won't wait. But we intervene at the most appropriate time, not immediately. If there is a complication only, we operate them on immediately. Whatever, even if they have complication, it is very important to resuscitate this patient initially. Basically, it is drip and suck.
So now again, I come back to the same question. What's the role knowing the etiology plays in your management? Is it important to know it?
I think to find
yes,
out
Rohan,
the etiology,
answer that.
I think it is your job to find the etiology. It's not our job.
No. I would say, like for a medical student, knowing the etiology might help when you meet up with a patient. For example, if you know it's a Crohn's patient, they can be having a Crohn's stricture. So you have a past history. It focuses you on the possibilities of obstruction. 2, it may also change your management, because if you're thinking of a tumor or something, maybe you can approach the patient differently, as a surgeon, you will have to be prepared to do something like to manage a tumor kind of thing. So knowing, not that you have to identify, but you have to have a vague idea of the list of etiologies kind of thing, isn't it?
Yes, of course, madam. Now, this comes a priority in certain patients. Now, as Pramod highlighted earlier, unscarred abdomen patient. If the patient haven't had a surgery in the past, or he doesn't have a hernia, which is complicated at the moment, comes with intestinal obstruction, we do believe that there is a cause we need to be recognized. When you do the X-ray also, if you don't see rectal gas, of course, and sort of distended large bowel in the old age patient, that also prompts us to think that this could be a rectosigmoid tumor. And the history, as you suggest, Crohn's, sometimes if the patient has a previous malignancy or
previous surgeries leading to adhesions or something.
So those patients, we think in line of obstruction. But the management plan, of course, first we resuscitate, look for the red signs, right? And then only sort of we give priority to find out a cause for the obstruction. Even the patient managed conservatively, we think it is adhesive obstruction if it settles.
Sir, can I just add on to that question?
So that is a clinic. A young patient comes with obstruction with blood, mucus, probably intersusception. Right? So they are also sort of we think of a cause. Cause is not that not unimportant, but it is not the first thing which we are going to hunt when a patient comes with intestinal obstruction.
So I think, as I see, there are 3 categories of patients. One category of patient, okay, if someone is coming with complication like localized peritonitis, perforation, or evidence of this impending ischemia, we don't spend time to find the cause. We need definitely we need to do something, so we resuscitate and we intervene. So that's one category of patient. And the second category of patients, they are not virgin abdomen, non-virgin abdomens, patients who had an operation, or maybe in that category, probably what Madam said, we can put them in that category. And that category, Madam, can you hear now? No.
Yeah. Can hear now. No.
Yeah. So second category is non-virgin abdomen, where they had operation early, or where it's a known patient with Crohn's disease. Patients, they are not coming in for operation, so we might observe them. And third category of patients, they are virgin abdomens and coming with obstruction without impending complications. And this category of patient, we are not rushing for operation. we can investigate probably for the cause, but still in a virgin abdomen, if they are coming with obstruction, generally the tendency is for operation. So you may look for a cause, but actually it doesn't really matter for your management, because in a virgin abdomen, generally they have a problem. So you still have, you are not rushing, but still your ultimate treatment would be surgery. So these are three categories as I see.
Yeah. Another category, of course. So basically, what Professor Rohan highlighted, the place of surgery in intestinal obstruction. One thing is when there's a primary cause, which will not sort of resolve spontaneously, like a tumor, stricture, right? So then at some point we have to do surgery. May not be immediately, but after a while. But resuscitation comes first in that group as well. Or another group of patients who are coming with complications with obstruction, like perforation, impending gangrene, ischemia, or evidence of ischemia. So those patients need urgent surgery. So there's another group of patients who we manage conservatively, but it doesn't settle. They don't have even sinister symptoms. After 48, 72 hours, still they have obstruction. Then we do certain investigation, confirm that there is an obstruction at some site. Then we do operate those patients as well. Usually they do have adhesions. And another group of patients are patients who are coming with recurrent obstruction. Patient comes 2-3 times a year. They settle, go home, come again, right? So this is also in adhesive obstructions. So usually we don't opt surgery for adhesive obstruction, but if patient doesn't settle or if patient comes repeatedly, in those two instances, we offer surgery for those patients.
Just to clinically correlate, sir, this type of 3 different patients. Now, this one is a 51-year-old patient who came with intestinal obstruction. And as you can see, the X-ray shows large bowel dilatation. So our management changes based on these findings. So we proceeded to do a endoscopy, to put a flexible sigmoidoscopy in him, because as you can see, the level of obstruction is very low. And this is what we found.
Can I interrupt, Pramod?
Yes.
Now, as this patient comes, would you do a CT scan first before doing endoscopy, or would you straight away do endoscopy in this patient?
I would do, if the facilities are available, I would certainly do. But in our setting, we did not have the facility to get a CT scan done acutely. And also the picture of the X-ray was sort of like the coffee bean shadow. And we were suspecting actually a volvulus of the sigmoid. So that's why we thought of let's not wait for the CT, let's put the sigmoidoscope in and see, because the obstruction seems to be at the level of the rectum. So we saw the cancer, and then we did not go for a complete laparotomy with resection, but we just diverted him proximally as a bridge to proper management of the cancer, as opposed to this patient who was a 21-year-old who came with severe vomiting, bilious vomiting, and there was minimal distension of the abdomen. And that patient, virgin abdomen, we went for a CT scan immediately and found out there was some sort of obstruction in the proximal bowel, and then we proceeded to surgery immediately, and to find out there was a large paraduodenal recess with a paraduodenal hernia, and was obstructed. And once we released, he was quite well. And this again was a 67-year-old female who is a known adhesive patient with adhesive obstructions. She gets about once or twice a year, she goes to the hospital with obstructions, and then they ultimately settle. But this time she did not settle even after 72 hours. So the CT scan clearly showed an obstruction, as you can see in the distal ileum. And she also underwent laparotomy, and to find out there was a band which was obstructing her distal ileum. causing proximal dilatation. So even in adhesive obstruction, there is a clinical decision that you make to go ahead and intervene surgically. I think these are real life cases, so which are good examples that intestinal obstruction does not always mean surgery, or you can't just have one recipe for all patients with intestinal obstruction.
So, so whatever, even if we consider surgery, even if we consider immediate surgery, all these patients needs resuscitation. Am I correct?
Yes, that is the only common thing in intestinal obstruction. And as medical students who are going to be house officers in the near future, they should always know there is a lot that they can do before the surgeon intervenes.
So what are the
identifying that it's obstruction and resuscitating the patient? As Sumudhu sir said, drip and suck. The drip and suck is the key for initial management of intestinal obstruction.
Yeah, but God's sake, don't mention drip and suck when you ask this question in the exam. It will not be tolerated or accepted.
It can mean many other things also.
Yeah. So when we talk about mnemonics, just so we don't sort of use mnemonics at the exams. Am I correct, madam?
Yes, please. I've always said, no, give your answers in full sentences and complete your answers so that the examiners don't have anything else to ask you. Otherwise, next they'll ask, what do you mean by drip? What do you mean by suck? No? So you have to give the whole answer.
So what exactly mean by drip and suck, Pramod? Or exactly what should they do sort of when a patient comes with intestinal obstruction initially? What should they do?
Yeah, so as we said, identifying clinically that the patient is in obstruction, number one, and then resuscitation. So you should basically achieve IV access, start IV fluid resuscitation, because these patients, when they come to the hospital, have a fluid deficit. As we said, there is sequestration plus lack of absorption. So you will start with crystalloid, like normal saline, and later on shift to Hartmann's based on their fluid status. Then nasogastric drainage to decompress the bowel until it's done as a bridge. You're not going to decompress the bowel for indefinitely. You will decompress the bowel until either the patient has surgery and gets surgical correction of the obstruction, or else if in adhesive obstruction, patient with adhesive obstructions, until it spontaneously settles. And then catheterizing, one of the very important thing that the house officer can do in his initial management. Catheterize and measure the output, because that is an indirect indicator of how well the patient is perfused. It's a very good indirect indicator of the level of perfusion. So these are basically the drip and suck. So you suck at two ends, the nasogastric tube and the catheter, and then you drip. You provide the you try to correct the fluid deficit and to give the maintenance fluid, because now patient's elementary absorption is not functioning. And then you can do the other basic preparation. You take blood for a full blood count, electrolytes, especially the potassium level, because potassium levels can be low, causing an obstruction, an dynamic obstruction, or it may be high because the patient has now gone into acute renal failure, acute kidney injury due to the hypovolemia. And serum creatinine levels are important. And based on your findings, the other investigations like amylase, if you're suspecting acute pancreatitis and so on. And then the imaging. The minimum you can do is an X-ray supine abdomen and not erect. We do not take erect X-rays nowadays. It's been given up. And if you suspect, perforation, take a chest X-ray, erect chest X-ray. Right. If you suspect perforation, you can take, or even in a supine abdomen X-ray, if there is a lot of gas, you can see the Wriggler's sign or the double wall sign, where air is on inside the lumen as well as outside. highlighting the bowel wall. And then CT scan of the abdomen, probably at a house officer level, you won't be able to arrange, but that will be, as we said, in a management plan, that will have a very low threshold, especially in a virgin abdomen.
So basically,
so there's a lot that how
dehydration. So not like hypovolemia, where you come patient following road traffic accident or something like that. It is easy to resuscitate patient with hypovolemia because you have direct access to vascular system or vascular compartment. Here, the fluid loss is mainly from the extracellular compartment and also from the intracellular. So you don't have direct access to that. So you have to depend on diffusion. So dehydration is a killer, more killer than hypovolemia, unless you you promptly hydrate them. So far we discussed how to recognize intestinal obstruction. That is mainly a clinical diagnosis. And this clinical diagnosis is based on 4 cardinal features, that is vomiting, abdominal pain, distension, and constipation. And those 4 vary in different sites of obstruction. And that will give us a rough idea about where the obstruction is. And the next important thing of an obstruction is whether he is having a problem due to obstruction or complication. Mainly we are worried about gangrene, ischemia, perforation. That is also mainly a clinical diagnosis. And then the next important thing is, we argued several times, the site of the obstruction. The cause of the obstruction, whether it is intestinal tumor, adhesions, foreign body, intersusception, so whatever it is. So the causes are heterogeneous. Then we were talking about the place of X-ray abdomen. We were telling you again and again, the most important X-ray is the supine X-ray abdomen, not the erect chest or erect abdomen. And when we consider other investigations like contrast enhanced CT scan abdomen, we talked about then how to resuscitate a patient with intestinal obstruction, because whether he is having complication with whatever the cause of the obstruction, if a patient comes with obstruction, one common thing they need is resuscitation and the aspects of resuscitation. Rohan, from where shall we proceed?
I think so.
We talk about the place of surgery as well.
Yeah, I think we I think this is last.
Yeah, place of surgery we discussed.
Yeah. Last.
Rohan, there is a question in the chat box.
Yeah. Last 15 minutes. Shall we keep it for question and answers? Already there's one question. Someone has asked, is there a role in arterial blood gas here? So what is, he's asking whether the place of arterial blood gas in obstruction or resuscitation or initial assessment.
Yes. Arterial blood gas do have a role. Not in early phase, one thing, arterial blood gas will help us to recognize ischemic bowel when in doubt. But we don't wait for the arterial blood gas. If it is not available, we have to rely on clinical grounds. But this is important to recognize ischemic bowel when in doubt. And other thing is now when there is ischemia, if the large portion of the bowel is ischemic and hydration is not adequate also, the level of to assess the hydration, we use arterial blood gas. So these are the 2 places which I can think we use arterial blood gas. And commonly we use arterial blood gas if a patient is having compromised renal function to because we can't hydrate them as we hydrate a patient who's having normal renal functions. But at the same time, we can't afford to underhydrate them as well.
Yeah, in this situation, in the arterial blood gas, most important if you can get is the lactate level. But
Yes,
the problem is,
that is the one which determines.
Yeah, but the problem is you don't get a rise in lactate level. If you, lactate level can increase due to various things. But main underlying cause anaerobic metabolism. So when there is bowel ischemia, you get that is one cause. But the thing is, for you to get a significant rise in lactate level, you should have a large part of bowel getting ischemic. But most of the time with intestinal obstruction, you don't see a massive, huge portion of bowel getting ischemic. It's a small part most of the time, but sometimes you can get. But in other side, these patients, they are underhydrated and their tissue perfusion is impaired. So they are actually having a tissue level, they are hypoxic. And that is another cause for rise in lactate level. So if you see a high rise in lactate level in this patient's obstruction, that indicates, okay, most likely the patient's tissue perfusion is impaired and probably there is significant part of bowel that is ischemic. Those are two possibilities. There's another question asking what is the place of prophylactic antibiotics? Okay.
Right. The complications which we talked so far were sort of the ischemic ones, then the hydration related complications and the electrolytes. And other complications are, as we touched just when we are talking about aspiration in intestinal obstruction. They have a higher risk of aspiration. That is why there is one reason why we place an nasogastric tube. Someone can argue that nasogastric tube per se itself can promote aspiration, but by and large, if you do it properly and if you manage it properly, the risk of aspiration can be minimized. Then the other complication is renal insufficiency if there is poor hydration, and the septic complication. The septic complications in the intestinal obstruction is mainly due to gut translocation and ischemic bowel. Then, so not all patients with, I don't routinely give prophylactic antibiotics in all patients having intestinal obstruction. But patients do have evidence of ischemia, patients do have signs of peritonism, or established infection like aspiration, pneumonia, or a risk of evidence of aspiration, yes, we start antibiotics. Rohan, anything to be added?
Yeah, I think I also agree with you. As for simple obstruction, there is no place of antibiotics. But if you suspect impending perforation, ischemia, for the complications, generally, yes, you think of you may give this evidence of benefit in antibiotics. There's another question. What is the ideal fluid? 0.9 saline, 0.9% saline, or Hartmann's?
Bhagya is not here.
Bhagya is here.
But I prefer Hartmann.
Amir.
Pardon?
Bhagya is here. Bhagya is here. Oh, you're silent.
Bhagya, yes, it is the question for you.
Yeah. Yeah. So it depends. The type of fluid that is preferred depends on what you're trying to replace. So if there is intestinal obstruction, there will be loss of fluid, loss of water and electrolytes. There will be loss of the electrolytes. Loss will include sodium, potassium, chloride, and so Hartmann's would be has a composition which is closer to the fluid composition of the fluid that is lost. Plus, if the fluid loss is large, and if you replace with large volumes of normal saline, it is known that these patients are at risk of developing hypernatremic, hyperchloremic, metabolic acidosis. So Hartmann's would be my choice of fluid as well.
Bhagya, can't you give them
Can I ask a
dextrose?
question?
Sorry?
Can't you, what if you give them 5% dextrose?
Yeah, 5% dextrose. Hello, are you there?
Yeah, yes.
Yes,
Yeah.
we can hear you.
5% dextrose. It depends on the distribution of fluid. The 5% dextrose will move into the, if you give 5% dextrose intravenous, moves into the interstitial compartment, and the dextrose is taken up by the cells. So you are left with water, and the water will then diffuse intracellularly because there is a osmotic gradient into the cells. So when you want to expand the intravascular compartment, say the patient has been vomiting for a prolonged period of time and his intravascular volume is depleted, and you want to replace the intravascular volume, you give dextrose, the fluid will end up in the intracellular compartment. So you will not expand the intravascular compartment. The patient has lost from the interstitial compartment, which is likely to happen if there is intestinal obstruction. Again, 5% dextrose is here because most of the fluid that you give will end up in the intracellular compartment and not in the interstitial compartment. So 5% dextrose would not be a good choice of fluid.
Okay.
Bhagya, as you hear, now
Yeah.
if a patient comes with intestinal obstruction with evidence of peritonitis, now this patient has come to the casualty in the morning, and he's vomiting as well. So can we take this patient to the theater immediately, or do we have to fast him for 6 hours?
No, we don't have to fast him for 6 hours because with intestinal obstruction, how much you fast, you're not going to get an empty stomach, because fasting basically is to prevent or minimize the risk of aspiration. Even if you keep the patient fasting for a prolonged period, the patient with intestinal obstruction will not have an empty stomach. Yeah, but that doesn't mean that you can rush the patient to theater, because this patient needs to be resuscitated first. It doesn't mean that you have to take hours to resuscitate, but maybe an hour or even for half an hour, 45 minutes, you can resuscitate a patient's volume status. Maybe if the patient requires antibiotics, I heard you discussing the indications for antibiotics, maybe start antibiotics, correct the electrolyte imbalances up to a point, and then take the patient to theater, but not, we don't delay simply to achieve empty the to make sure that the patient's stomach is empty. No, that doesn't happen if you give the patient fasting. So delay will be to resuscitate the patient, not to ensure an empty stomach.
Pramod, you had a question?
Hello, yeah, I was good. When the patient presents initially, if he has a large deficit and you want to give boluses and boluses of fluid, still would you use Hartmann's as boluses, or it's going to be normal saline, the resuscitation fluid?
If your patient has a large fluid deficit, that's the kind of patient who will benefit the most from a balanced salt solution like Hartmann's. If you replace a large deficit with normal saline, they are the patients who are at high risk of developing this hypernatremic, hyperchloremic metabolic acidosis. So Hartmann's, yes, Hartmann's would be the fluid of choice. But if the patient is severely intravascular volume depleted, we might even use a colloid initially to avoid using large volumes of crystalloid. So we can use colloid as well.
And in those with proximal obstruction, having a lot of vomiting, hypochloremia, that they would you still prefer to go with sodium chloride, or
proximal bowel obstruction?
Outlet obstruction.
Gastric outlet obstruction.
Though we say that we know that the chloride content in Hartmann's is less than in normal saline, but the chloride content in normal saline is supraphysiological. It's 154 millimoles per liter, whereas the plasma concentration is only 140. But if the patient is grossly hyponatremic or hypochloremic, hyponatremic especially, then you can correct the sodium, but you have to be very careful when you correct the sodium. because rapid correction of sodium can cause a lot of other neurological problems, particularly. So correction of hyponatremia is a different issue, but even then Hartmann's would be the fluid of choice, but hyponatremia can be corrected using either hypertonic saline or normal saline.
Now this gastric outlet obstruction patient, because of vomiting, they lose chloride also.
Yes.
They get hypochloremic. So
yes.
Isn't the sodium chloride the best solution? Just what I feel.
Yes, but these patients will also lose a lot of hydrogen, H+ ions, because they'll be vomiting out hydrochloric acid. So these patients would be more likely to develop an alkalosis because of the loss of hydrogen ions and chloride ions. So yes, depending on it, it is an individualized treatment. You assess the electrolytes. If the patient is hyponatremic, hypochloremic severely, you might have to replace these electrolytes as well. But keeping in mind that large volume resuscitation with normal saline can result in a hyponatremic state, hyperchloremic state, plus the fact that you're not replacing any other electrolytes that are found in Hartmann's, like potassium. So if you are replacing with normal saline or correcting with normal saline, you have to make sure that the patient gets additional potassium in the form of a potassium infusion.
There are a couple of more questions, but for students, now during this discussion, I think you all heard a different spectrum of depth. We talk very superficial things, we talk concepts, and we talk few facts, and now you probably heard some of the complex things. So how much to grasp is up to you, because you can't grasp everything, but you grasp something. But then eventually, as you progress, you can fill up the blanks. So don't get bit depressed when you hear certain things that you don't understand, but eventually we learn these things. So there's another question: how long can we observe in non-setting, in non-virgin? So basically, what this person is asking is, in non-virgin abdomen, how long can you wait without intervening?
Yes, this is now Pramod also mentioned that we wait for 48 hours to 72 hours. These are arbitrary figures. You know, these are not magic figures. Now in 48 hours something happens, and these are observation based figures. Now what we have observed is adhesive obstructions due to adhesions. Now these obstruction, the primary pathology is outside the bowel. There is no problem within the bowel or in the lumen of the bowel. These obstruction due to adhesions set about 90% of them settles within 48 hours. So some say it is about 70%, but after waiting for 72 hours, the chances of settling is very low. So if they do develop signs of peritonism, of course, we don't even wait for 24 hours. But if they don't develop signs of peritonism, we roughly wait for 48 to 72 hours. But waiting beyond that, the chances of spontaneous settling is very minimum. So this is evidence-based. So in these patients, we prefer to do if you do have to wait due to sort of some other reasons, like patient is not a very fit candidate for surgery or something like that, we probably have to do a contrast CT scan or at least small bowel MRI or contrast follow through to make sure we are dealing with adhesive obstruction and it is not a complete obstruction. If it is a partial obstruction, of course, we can wait a little more. Otherwise, at the end of 72 hours, some surgeons prefer after 48 hours, we opt to operate them.
Yeah, this is traditional saying that the sun should not set twice on obstructed bowel. So that indicates that's a sort of a traditional this thing. So I think next question, laparoscopy. What is the place of obstruction? Diagnostic laparoscopy.
Now, if I give a blanket answer, laparoscopy, colonoscopy is not a frontline investigation or tools which we used in intestinal obstruction for obvious reasons. Now, if there is obstruction for endoscopy, colonoscopy, we have to insufflate air into the bowel. So we distend it further. So if it is not already gangrenous, we can make them gangrenous if you sort of distend the bowel more. So they are not frontline investigations. Laparoscopy, the issue is when the bowel is distended, it is not safe to insert ports into the abdomen because the distended bowel touches abdominal wall, not enough space. Even if you go in, the moving bowel and doing a procedure is not that safe, and it is very difficult. But having said that, there are special instances. If you do a CT scan or X-ray abdomen, you see that the bowel are not that distended, and there is a sharp cutoff at one particular place, and you think it is an adhesion. You can resect it and resect it. Then, of course, you can do laparoscopy, and laparoscopy has a remote place in intestinal obstruction. Management of the intestinal obstruction.
Yeah, so you might say it's not contraindicated, but in a selected patient, there is a place in laparoscopy. So I think next question is for Bhag, you can answer this. If the patient maintains normal hemodynamics despite dehydration, will you consider infusion 5% dextrose to increase cellular water intake?
It's a very good question.
Yeah. Bhag, are you there? Bhag, I think it just got blocked off. I think so, sir. Can you answer
that? Now, the most of the fluid loss in intestinal obstruction occur in the interstitial space. So what we should choose is a fluid which replenishes the interstitial space. Not the intracellular compartment. If you give dextrose, true, it replenishes the intracellular compartment, but what we want is to replenish mainly the interstitial space or the extracellular compartment. So I think it is not appropriate type of fluid in intestinal obstruction.
Yeah, okay. Next question. What is the place of ultrasound scan as an imaging modality in diagnosis? I think the problem with ultrasound is it's a sound wave, and sound wave does not travel through gas well. And if in intestinal obstruction, you get distension partly because of gas, and your ultrasound waves will not traverse through the gas, and your picture quality is very, very poor in ultrasound. So generally, ultrasound will not give you much information in place of obstruction.
Having said that, if you are suspecting of intersusception, ultrasound have pathognomic appearance in intersusception. So there is, how do we say, there is a place, remote place, and in certain conditions, suspecting of intersusception. Pardon?
Target site. They call it target site.
Yes, yes. So you can't say there is no place at all, but there is a remote place in certain circumstances.
What is the what is the initial resuscitation fluid used in severe dehydration? I think we discussed this.
One, can I come in for a bit?
Yeah. Yes.
As a general principle, I think we need to give fluids. We need to find out which compartment is most likely to have lost fluid. So whether it's a intracellular compartment, interstitial compartment, or the intravascular compartment. So this you can decide on this by going through the history and examining the patient. So if you have a patient who has had bowel obstruction and has been vomiting for a prolonged period, and the patient is also tachycardic, patient's blood pressure is low, patient's urine output is low, patient feels thirsty, put all this together, all this tells you that the patient has probably lost fluid from all three compartments. Patient has lost fluid from the interstitial compartment initially, we know that in the bowel obstruction. Patient will have loss of skin turgor, patient will have feel thirsty, and then if once the interstitial compartment loses fluid, and if the fluid loss is prolonged, then there'll be loss from the intracellular intravascular compartments. When the patient loses from the intravascular compartment, patient's blood volume drops, therefore the urine output will reduce, the blood pressure will reduce, and the patient will become tachycardic. So all those are indications of intravascular volume loss. If the patient is in addition confused, restless, also means that there is significant intracellular volume depletion. So based on your clinical signs, the symptoms and the signs, you should be able to, in most instances, say from which compartment the fluid loss has been. In addition, we use our blood gases, laboratory tests like the serum electrolytes to help us to decide which compartment is most depleted and which electrolytes are or which electrolytes need to be replaced. So it's a combination of history, examination, lab investigations, which will tell you which compartment or compartments need to be resuscitated and which electrolytes need to be replaced or replaced, or whether patient needs acid or base replacement.
Yeah. Are we going to continue, or we have a couple of more questions, or we shall stop?
Diluk just wanted to mention about the closed loop obstruction for completeness sake. Mention that when the ileocecal valve
Yes, Pramod, go ahead.
and when there is a distal colonic obstruction. Yeah, so when there is a distal colonic obstruction, and if you have a competent ileocecal valve, which is very arguable, you will get what you call a closed loop obstruction, because there will be only one way flow of fluid into the colon, and the chances of perforation are very high because there is no space for the proximal small bowel to get distended, and the fluid will accumulate in this closed part between the obstruction and the ileocecal valve, and there's a higher chance of getting perforations. So just to mention, if you come across the word closed loop obstruction, and when decompressing this bowel, you have to think of that as well, because having a stoma in the small bowel with a closed loop obstruction is not going to relieve the obstruction. You will have to decompress the large bowel.
Yeah. So we'll have one last question. And for the students, there is, can you please put up your feedback on how to improve, not just tell that, okay, this is, like we all mentioned the last time as well, not to praise, but just to, if you have any suggestions and if you have any thoughts of how to improve this, let us know. And there is a link in the Facebook. You can go there and give your feedback. Last question, the role of barium meal in bowel obstruction.
Who is going to answer?
It has no role in acute intestinal.
As I'm the oldest man in the forum, I think I should answer. Those days we used to use barium meal and follow through in intestinal obstruction, but nowadays I think it is not even, we don't even hear about barium. No one requests, and it is not a issue at all at the moment, because no one requested. There are several issues with barium. One thing is barium is a thick substance, and it causes, now when there is a problem, if there is a perforation, if there is ischemia, gangrene and perforation, barium is a very irritant to the peritoneal cavity. So if you fill the bowel with barium, and in case he develops a complication, we are facing another added complication, barium peritonitis also. So that is why we don't sort of use it. And other reason why we don't use it is we have more safe, more informative investigations at the moment to recognize the site of the obstruction, cause of the obstruction, whether it is complete or not, or whether there are complications of the obstruction. Those are the four most important things which we want to find out in a patient with obstruction. So all practical purposes, barium meal is out today.
Is barium used
gastrography
at all?
can be therapeutic.
Is barium meal used
Pardon?
at all? Is that investigation used? Isn't it obsolete now? Almost.
Yes, it is not safe now. We have more safer ways. Those days, of course, barium was used because they didn't have water soluble, the iodine based contrast readily available. So only available contrast was barium. So they did use it. When the patient doesn't have evidence of perforation, they used it.
And I think water-soluble contrast can be therapeutic as well. I think worth mentioning it for a completeness sake.
Yeah, barium. Other to adapt onto that, add to that, barium. If you, people think of barium, mainly look at the small intestine, but there are other investigations that we nowadays we can use to look at the small intestine, like MRE, enteroclysis, or capsule endoscopy, sometimes endoscopy. So there are other better options than barium nowadays. Madam, anything to add as the last?
Not really. I hope that the student realized how important your physiology is and the importance of fluid balance. And so you have to know your basic physiology to do a proper fluid balance this thing. And pathology, as a surgeon, you have to know to identify gangrenous bowel when you open up. Otherwise, you'll end up resecting wrong bowel loops and sending it to us, right? So, and also perhaps the anatomy, because you have to know these various sites, the blood supply to the bowel. Most of those we touched on today, I believe, but maybe you can, as Professor Rohan said, fill in the blanks and adapt. This is the basic skeleton that we have given you. So the bricks and the mortar and the interior decoration you have to do. So shall we call it a day then?
Rohan, just a small point I want to bring up.
Yeah.
So we quite often we have patients who have developed a perforation. I don't know if it's appropriate to discuss now. They present with clinical features which are common to other conditions like pneumonias and other infective complications. They'll be tachycardic, they'll be tachypneic, but it's important, I think, to have a high index of suspicion of bowel perforation in this setting. There may be a patient with intestinal obstruction, but if the patient is tachycardic, oliguric, it's not only a respiratory tract infection or a urine tract infection that can produce these clinical features. Could very well be a bowel perforation. I don't know if it's worthwhile highlighting this. Sumudhu?
Sumut is there?
Yeah. I'm on another call, but sort of.
Because quite often we find patients being managed inappropriately because people tend to think that this is a respiratory tract infection that's causing all this morbidity. When it's obvious that the patient's abdomen is distended, patient has not been passing stool or not passing flatus, and we are treating a respiratory tract infection when it's actually a bowel obstruction. Quite often, these patients will have an elevated serum lactate. So that is also another clue that there is something not quite right with this patient.
Yeah, what you said is, I think, much more appropriate in patients after surgery. Where now, if you, let's say, if someone comes with pure and simple small bowel obstruction with a later on developing complication, generally these patients' abdominal signs will, if you go to the history in detail, they start with the abdominal symptoms and then subsequently they get other complications and other symptoms. But what you said is very applicable for post-operative patients because they are already having pain after the surgery. But then as a let's say someone develops obstruction and bowel perforation and peritonitis, and that can manifest as a respiratory tract infection. So actually you might miss the problem in the abdomen if you try to focus on the chest. So in these patients, especially post-op patients, the presentation of intestinal obstruction may not be typical picture that you get in non-operative patients or patients who had not had any surgery before. Yeah. So shall we conclude for the day or?
Yep.
Just a quick one, Rohan. Here the students also might be able to suggest topics for you all, no? If there's anything they'd like to discuss, any cases or something, they also can be a bit proactive about it if they want.
Yes, madam, they can give a feedback in the feedback section. There is a place where they can type their thoughts and suggestions. So in that section, they can put up what they want. This is what we thought they want, but actually they may want.
No. I mean, if they feel that there are some things that they'd like to discuss, they can maybe suggest. Eh?
Yes. Anything to add, sir?
That's fine. I think we didn't. This is not a comprehensive touch of intestinal obstruction, but we touched most of the important things, and we highlighted over and over again about the most important aspects. And there were a lot we didn't touch, but they can go and read.
Yeah.
Yes, so thank you, everybody.
Yeah.
Thank you, madam.
Thank you, madam.
Thank you. Good night. See you tomorrow at work.